Hello, everyone. Welcome. Bonjour tout le monde. Thank you for joining us for Heart and Stroke's Women's Heart and Brain Health Research webinar series, Research Impacts and Opportunities 2. A couple of housekeeping things before we get started. We have two ways to join today for audio. So you can join us via computer audio, in which case please make sure your speakers are on and volume turned up, or you can join us by phone call. You'll be provided with a phone number and you can dial in to listen that way. Please make sure that you're muted. Everyone should be muted, but in the event that you're not, please make sure that you are to improve the audio quality for everybody. We'll be taking questions through our question box in the GoToWebinar platform. Please type in your questions as they occur to you. I will forward your questions to our moderator, who will then field the questions and direct them to the appropriate speaker. We will be recording today's webinar, and the recording will be available after the session on Heart and Stroke's YouTube channel. We'll also be sure to send the link to everyone following the session via email. Also by email, we'll be sending a link to a survey, and we ask that you please take a few minutes, it's a very brief survey, to let us know what you thought so that we can inform future programming like this. We're very pleased that you joined us today, but we hope that beyond today, you'll help keep the conversation going. So I encourage you to follow us on Twitter at Heart and Stroke and use the hashtags #Heart and Stroke Science and #BeatInEquity. If you haven't already, I'd also ask that you please mark your calendars for tomorrow's event, which will be the third webinar featuring some of the researchers who've been funded through this initiative. And then finally, next week, as the final installment as part of this series, looking at a way to build upon the progress we've made in sex and gender in research, taking a more intersectional approach to advancing the field. Now, before moving into the body of the program, I want to pause and acknowledge the land from which I'm joining you today here in Ottawa, Ontario. It's the traditional and unceded lands of the Algonquin and Anishinaabe peoples. And particularly at a time where we are being told to shelter in place or to stay in place and limit our movement, I encourage you to think about what that place means and the histories of that place and the living histories of that place, the people that you are surrounded by geographically and socially in your communities. I also want to acknowledge that we find ourselves in the midst of a crisis with COVID in Canada. And I know many of you are on the front line, and I want to thank you for your work in fighting this pandemic. We also know that COVID has exacerbated persistent and historic inequities, and we are joined today because of a shared commitment to addressing health inequities. So, though it's impossible to ignore, I encourage you to think about that as you listen to our speakers in our presentation today. Health inequity is really the impetus for this initiative. And in 2016, we received 5 years of funding from Health Canada to contribute to new knowledge related to women's heart and brain health, which could ultimately change policy and practice, but also to advance capacity for those working in the field and ultimately adopt sex and gender-based analysis and reporting by research funders across the country. And we've accomplished this by partnerships, by holding knowledge translation events like this one, but also by funding research directly. And significantly, we were able to leverage that initial $5 million investment and turn it into $8.5 million through partnerships with CIHR, which made possible the funding from some of the researchers you'll hear from today, but also through donor dollars. And this has resulted in the funding of 26 projects across the country, all looking at sex and gender in different ways. We have also, importantly, used this initiative really as a catalyst for fundamentally changing the way we fund research at Heart and Stroke. Even last year, with the economic downturn really impacting the charitable sector, we were able to fund approximately $17 million of research, and all new research competitions require sex and gender to be accounted for in those guidelines. So today, we are going to hear from some of the findings, some of the progress from 3 of our chairs, as I mentioned, funded jointly through Heart and Stroke and CIHR, but also hear some of the reflections about where the next steps are and where the field can progress. And we are in very capable hands with our moderator, Dr. Varinder Randhawa, who holds an MD PhD in internal medicine and cardiology. She's currently undertaking postdoctoral training at the Cleveland Clinic, following a clinical fellowship in advanced heart failure and transplant cardiology. She's also been the recipient of numerous research awards, including the prestigious Cossack Research Award for her work spanning translational, clinical trial, and registry-based studies on diabetes, heart failure and transplant, resuscitation, and shock and mechanical circulatory support outcomes with a gender diversity lens. She's received funding from the CIHR Doctoral Award and MD PhD studentships, as well as from a CIHR Planning and Dissemination Grant, as co-PI with her colleague, Dr. Laura Banks, for her work on gender diversity. And now over to Dr. Randhawa.
Thank you very much, Kristen, for the kind introduction. It's my pleasure to moderate today's session with three very accomplished speakers. If we can move to the next slide. Dr. Heather Foltz is a Métis scholar in the College of Kinesiology at the University of Saskatchewan and the Heart and Stroke CIHR Indigenous Early Career Women's Heart and Brain Health Chair. She is a co-scientific director of the Healing Together Métis Health and Wellness Research Network. Her research focuses on Indigenous peoples, women's and cardiovascular health, and the importance of culture and social support for health. She will be followed by Dr. Karen Nirenberg, who is an associate professor and clinician scientist at the University of Calgary, working in the areas of general internal medicine and obstetric medicine. Dr. Nerenberg's clinical and research interests focus on the prevention of cardiovascular diseases in women after common pregnancy complications, in particular the hypertensive disorders of pregnancy. Her research is also supported by CIHR and Heart and Stroke's Women's Heart and Brain Health Mid-Career Research Chair, through which she founded and leads the Canadian Post-Pregnancy Clinical Network. And finally, but not least, Dr. Bernice Downey is a woman of Ojibwe and Celtic heritage, a mother and grandmother. She is a medical anthropologist with research interests in health, health literacy, and Indigenous traditional knowledge, and health research system reform for Indigenous populations. She is one of the Heart and Stroke and CIHR Early Career Chairs in Indigenous Women's Heart and Brain Health. She is the Associate Dean of Indigenous Health and Assistant Professor in the School of Nursing and Department of Psychiatry and Behavioral Neurosciences in the Faculty of Health Science at McMaster University. It is my pleasure to hand over to Dr. Heather Foltz to begin the session. Thank you.
Hello, thank you for that introduction. The next slide, please. So as you heard, I'm a Métis woman, and I'm joining you today from Treaty 6 territory in the homeland of the Métis in Saskatoon, Saskatchewan. Next slide. So the project that I am presenting to you are findings and work today is from the Heart and Stroke CIHR Early Career Indigenous Women's Heart and Brain Health Chair. I'm currently on parental leave, and so in terms of the timeline of the project, I'm nearing the end of the second year of the funding. Next slide. So the main objectives of this project begin with reflecting the Indigenous worldview, which is often more holistic in terms of our understanding of health. So the incorporations of physical and mental health, but also the social experiences, social connections, and our cultural and spiritual aspects. So I'm partnering with a Métis community in Saskatoon, as well as the Indigenous community at the University of Saskatchewan in this project. And overall, we're looking at how cultural connectedness and social support are determinants for cardiovascular health. This project is a focus on Indigenous women, so looking at sex and gender specific results in this project. Next slide. So why does this research question matter? Cardiovascular disease is more common among Indigenous women than non-Indigenous women, and experiences can be as high as 2 to 3-fold greater. One of the alarming concerns is that cardiovascular disease is increasing among Indigenous women, in contrast to the plateaus and declines we see among the general population of women. A lot of research combines Indigenous identities and nations and looks at an overall Indigenous idea of a population and often ignores Métis. So this project, working specifically with Métis women, helps to bring our understanding of that specific group. The risk profiles are unique among Indigenous people, and that would include different social experiences, the experiences of colonization that underlie all aspects of health and life, the social differences, economic, political inequality, and experiences of assimilation and discrimination. Next slide. So addressing the gap, considering those other aspects of health, of cultural connectedness and social support, focusing specifically on Indigenous women and particularly experiences, and identifying determinants of cardiovascular disease that might be specific to Indigenous women and Indigenous people. Next slide. So the first study that we were working on in this project is a qualitative investigation using interviews and Photovoice. We've currently completed the interviews and the thematic analysis is just wrapping up. Some of the main things identified bring the idea that the connection to the land and even within a city, trying to find land and places to be to maintain that connection impacts your health and well-being. The second part of the study is a survey of physical activity and sedentary behavior with cultural connectedness and social support. We completed some initial analysis and identified some important determinants of experiences of your social support network, especially your community, experiences of discrimination, things that can really impact how physically active you are, which could impact other aspects of health. We're currently recruiting some more participants so we can look at gender-based analysis. And then the next step will be to do a quantitative comparison of cultural and social determinants with determinants of cardiovascular health. So this study, we've discussed the study with the community advisors, but we've not started data collection because of the pandemic we're currently in. Next slide. So as I said, a focus on Indigenous women in my work, and we're looking at that both from a sex and a gender aspects. So sex, we've been asking participants what their sex was assigned on their birth certificate and looking at the evaluation separately by sex. Gender is a bit more nuanced, so we've been using the personal attributes questionnaire, and there's the reference there, and this evaluates gender on a continuous spectrum, so it can then be evaluated as a covariate, and it's not not as strictly linked to sex, so it can be evaluated separately. Next slide. So in terms of community engagement, there's a couple of different levels here. All of this research is done in partnership with communities. So I've been partnering with Métis, Saskatoon Métis Local 126 and the Indigenous community at the University of Saskatchewan. For all of these studies, we have community advisors who are elders and community members who provide input on the designs, the questions, the surveys, the order of the questions, the order of the questions. And then we come back to the advisors and go through the analysis and the themes and help to understand what it means. They are authors on the publication. Sometimes they want to be included and sometimes they don't. And then in terms of sharing the results, it's beyond the academic knowledge translation session. So we usually have an event where we share a meal with the community and share our results, get their input, and before we would pursue academic publication. Next slide. So the knowledge translation and those community aspects, we've had some lunch and learn sessions at the university with the students and staff and faculty. We are hoping to hold Métis kitchen dances with the Métis community. We were in the process of planning one when the pandemic hit, so that's kind of on pause for the moment, but we've been looking at doing virtual type seminars that we can engage in this type of environment while we're maintaining distancing. And then of course the typical academic knowledge translation avenues of publications and presentations. Next slide. So partnerships and collaborations. I am working with, of course, the Indigenous community partners. The institution, my University of Saskatchewan, has been a partner on this and supporting the graduate students who help out on the work. The Saskatchewan Indigenous Mentorship Network has been an important partner in funding some of the undergraduate research assistants who are helping out with these projects. Our Indigenous community partners and advisors are important components. And then I've been able to match funding with the Saskatchewan Health Research Foundation to maximize the infrastructure available. Next slide. Of course, the pandemic has changed where we're at. We've paused all in-person data collection with the Indigenous community following the pandemic. Ethics approvals have taken a bit longer in our times, and as you can see, I'm working from home with a young family, so things are a little bit different. So some of the adaptations we've done, we've expanded the early studies, so doing some extra layers of the Photovoice qualitative project that helps additional Indigenous women do some somatic analysis and identify some greater layers of building more community partnerships and working with these projects, and we've shifted some of the projects that are a part of this work. Next slide. So some of those opportunities that have happened, as I said, we did some extra qualitative interviews last summer when we were staying at home, and have had some extra Indigenous women, additional Indigenous women provided some analysis. So we're getting a greater richer analysis there. We've expanded the physical activity survey, which is done online, so get some extra and more participants so that we can look at more layers of gender. And then we've been discussing some new qualitative studies with communities. We're not ready to finalize any of that, but trying to expand on the work we can do while we're remote and building relationships with communities that are not currently participating in this that we're doing. Next slide. So some of the greater implications, this has added a lot of strength to the qualitative methods and experience, and it's given more time to focus on community relationships. So our next steps are to prepare for that in-person quantitative study when it's safe within the pandemic experiences, developing some new qualitative studies and some new partners participating in those studies moving forward. Next slide. So I'd like to say merci and thank you for being with here today. And I apologize for the noise. Somebody cut his nap a bit short just before this started.
Thank you very much, Dr. Foulds, for your wonderful presentation on your foundational work with the Métis population in Saskatchewan. For anyone who has questions, please enter them into the Q&A, and we will have a Q&A session at the end. It is now my pleasure to hand over to Dr. Karen Nirenberg to describe her work.
Okay, well, now can you hear me? I hope. Well, thank you for the introduction and for the opportunity to present our research. Next slide, please. First, I want to acknowledge the traditional territories of the people of Treaty 7 region in southern Alberta, which is also home to the Métis Nation of Alberta Region 3. I also do want to acknowledge the support and my gratitude for that support from Heart and Stroke for the new investigator award I received from Alberta, which I'm in year 3 of, and the Women's Heart and Brain Health Mid-Career Research Chair, which I'm really in year 2 of, because like Heather, I've come back from a parental leave. So my child, I think, is equally as active, but walking. So next slide, please. Sorry that this is all on one slide and it's not animated for the purposes of today's presentation, but I've included a lot of the background work of our research here on this one slide. And what we tend to focus on is this area in the top left-hand side of your screen. You'll see that women who've had several pregnancy complications, the highest risk one is the hypertensive disorders of pregnancy or preeclampsia. But women who've had several pregnancy-related disorders identify them as being at risk of premature cardiovascular diseases. And that's not just heart attacks and strokes at an early age, it's the development of multimorbidity fairly quickly after pregnancy. So the development of high blood pressure, diabetes, sorry, I didn't start my timer here. High blood pressure, diabetes, high cholesterol, kidney disease, etc. We also know now that there's a ton of epidemiologic data about this, but it's time that we start moving beyond this epidemiologic data. And how can we tailor this data a bit more precisely in a precision population health lens to actually start tailoring interventions to the women who are at the highest risk of these complications? Another novel thing we're trying to do with this data is how can we use all of this pregnancy data and cardiometabolic data in the years after pregnancy to create surveillance systems that gives us a sense of the future health of our population. I often say that we have this cardiometabolic tsunami coming our way, and we need to start figuring out how we're going to address this from a population health perspective. What you can see now in the bottom left-hand corner is the current state of care of women in Canada, that essentially we lose about 25% of women from hospital discharge to a specialty clinic for follow-up. Beyond that, we lose another 50% to their follow-up visits. So how can we as a clinical and research community do better so that we don't lose these women out of the pipelines? What we're working on here is, number one, identifying what are the best practices that we can do for preventing, screening, and managing these cardiovascular risk factors, so high blood pressure, diabetes, high cholesterol. But further than that, how can we go beyond and actually implement these interventions where we can actually target them directly to women with lived experience to educate them and empower them in their preventative care journey? And how can we also address gaps in clinical care at the clinician level to increase awareness, but also support interventions in primary care? We all know that primary care is pretty bare bones these days. COVID has really heightened some of these inequities. So how can we embed some public health resources at the community level for our clinicians? So these are the targets of our interventions: health systems approaches targeting women with lived experience as well as their clinicians. Next slide, please. Oh, sorry, oh, perfect. So where are we at with some of the results here? Well, first of all, we've created a provincial surveillance system that I call APPLES, or Alberta Pregnancy and Postpartum Longitudinal Evaluation System. And the purpose of this was to bring together an entire administrative data set of pregnancy-related outcomes, general health systems measures that are collected during hospitalization, emergency departments, and outpatient visits, and supplementing that with data from laboratory data and drug data, so we can get a sense as to what is the health burden of the comorbidities in our population over time. And what's been shocking, our preliminary results from APPLES has identified that all of these pregnancy-related cardiovascular risk factors have increased over a 10-year period in Alberta, was increased by 25%. So now, when we think about delivering healthcare in our province, every year we have to reach 11,400 women with some messaging, education, and screening. So that's a big number of women that we need to reach. Our next steps are looking at where can we reach them? How can we piggyback and take advantage of routine clinical care to reach these women? Next slide, please. In terms of other results, through Heart and Stroke support, we were able to establish the Canadian Postpartum Clinical Network. This involves 17 clinics from across the country. We were able to pull them together to develop a clinical research collaboration where, number one, we could establish the best practices for preventative care and then work on ways to implement and evaluate the impacts of those interventions. Next slide, please. We've created over a multi-year process our best practice statement, which included interdisciplinary clinicians, women with lived experience, policymakers, and researchers working in the field in these clinics from across Canada so that we could identify the components that are required for best practices for preventative care. In parallel with that, we collaborated with McMaster University to do the evidence review so that we could provide grades for this inaugural best practice statement, which will be an international leader in the field. At present, we're preparing for our final round of Delphi consensus and grading through McMaster Evidence Center. Next slide. How will we report our sex and gender-based research? Sex, at present, we have no opportunity for comparisons as we're focusing on the a biologically female population. We have received feedback that it may be important to look at their partners as well as other males in administrative data, and we'll look towards that in the future. Gender, we're planning to incorporate various measures of gender from administrative databases as well as prospective collection and their impact on outcomes to identify whether there are any gender-related barriers to preventative care. We're working with Dr. Ann Peterson from the University of British Columbia, who developed a framework called Transformative Health Promotion Interventions. Our theory is that many of these interventions that we're trying to implement and assess actually are gender transformative in that they reduce societal or other barriers to care for new moms. Next slide, please. What knowledge translation opportunities? So we've done some community engagement, we're disseminating our results, and also involving some community partners, which we'd like to expand, as well as organizations. Academic, we've presented our findings at the usual national and international meetings, as well as been incorporating these findings into clinical practice guidelines. We're starting to have some conversations with policymakers at local, provincial, and national levels, particularly partnerships with the province of Alberta, strategic clinical networks that are focused in cardiovascular and stroke and maternal and child health to help us with these systems level interventions. We're very fortunate to continue to partner with Heart and Stroke on upcoming opportunities, as well as our clinicians and researchers from across the country in the postpartum clinics. We have engaged people with lived experience to help inform the research projects, as well as including women's preferences in the best practice statement. Next slide, please. Unexpected challenges. So again, COVID. I think outside of COVID, we identified a challenge with our best practice statement with the evidence review. It was more restrictive than we had anticipated, and therefore we had to redo it. So we went from having 8,000 citations reviewed to 24,000 citations. But this has created a tremendous opportunity to provide a very comprehensive state of the science review on health after pregnancy. COVID has certainly delayed the launch of our Canadian postpartum clinical or post-pregnancy clinical network. Importantly, because many of the clinicians in this field are internists caring for the inpatients, and therefore we've delayed all of the launch of the statement and the interventions we'd like to proceed with. However, COVID has been a tremendous opportunity to respond to women's requests for virtual care and assess whether virtual care reduces gender-related barriers and is in fact gender transformative. So we're really hoping to capitalize on these opportunities for virtual care at a health systems level because it's made it possible. And in general, we've had increased opportunities over the years. Next slide, please. In terms of next steps, the best practice statement that I mentioned previously is in this last round of Delphi consensus, and we anticipate to have it out sometime in the summer or fall of 2021. Next, after that, we'd like to convene an international working group to create an international standard of care for women. We are planning to evaluate the impacts of best practices on health outcomes through a national database as well that is being funded through this chair, and with plans to turn that into a national surveillance system for chronic disease management in partnership with several other organizations. We plan to use the information that we're obtaining on sex and gender, ethnicity, race, and social economic status to look at these, and mental health as well, to look at their impact on cardiovascular outcomes so that we can use this information to inform personalized interventions. And finally, through patient engagement, we've identified a strong need to actually carry out a research priority setting initiative so that we can actually identify and answer the questions that matter most to women with lived experience. Thank you for the time to present this today, and I'll take any questions at the end.
Thank you very much, Dr. Nirenberg, for your wonderful presentation of your work. With that, I'd like to move on to Dr. Downey for her next presentation. Please remember to enter questions into the Q&A. Thank you.
Big Witch. Ani, hello everyone. Thank you for the opportunity to share a little bit about my work. I apologize, the video function for my computer is not working today, so it's just my audio. I'm here as a visitor on the traditional territory of the United Nation of the Thames, Haudenosaunee area, the Chippewa of the Thames First Nations, and the Munsee Delaware Nation, which is part of the Lenape. I'd like to acknowledge the Heart and Stroke Foundation funding agency and the Canadian Institute of Health Research, in particular, the Institute of Aboriginal People's Health, the Institute of Circulatory and Respiratory Health, and the Institute of Gender and Health, and also the New Brunswick Health Research Foundation and the Social Science and Humanities Research Council for the funding for this project. With me. Next slide, please. So this is a schematic which shows you all the various components of the project. I was awarded the Indigenous Early Career Women's Heart and Brain Health Chair in 2018, and we're currently in the third year of the research funding. So this is a visual overview of the main project elements with a breakdown of the activities in 3 project phases, years 1 and 2, and then 3 to 5. And so we'll just provide a high-level overview of the project and later can discuss our current progress and some of the delays and challenges related to COVID. The primary goal of this research is to expand the body of knowledge regarding Indigenous women at risk of or living with cardiovascular disease and stroke. And we hope to understand how Indigenous knowledge and ways of knowing about well-being can assist Indigenous women with their own personal agency and ability to manage their cardiovascular disease or stroke treatment. And this research supports the importance of cultural beliefs about the role of women within their families, communities, and nations, and contributes to their knowledge and ability to take charge and manage their own journeys of healing. The other focus on this project is on healthcare providers who work with Indigenous women, as they are generally inadequately prepared to work with Indigenous populations, and the way that they provide health information to Indigenous women is often not done in a way that is sensitive to people's cultural needs and safety. And so the goal here then is to develop educational programming for healthcare practitioners about Indigenous and gender-based ways of working with our women, and about an Indigenous health literacy approach to help improve cultural competency. And finally, this research also contributes important information about sociocultural variables linked to how Indigenous women experience heart illness to positively inform policy development and clinical healthcare provider guidelines about this population. And we hope to contribute to the emerging Indigenous knowledge base being cultivated by Indigenous and non-Indigenous researchers across the country. So what you can see there then is the various activities. So I'll just, focus on year 2 that we held a community members gathering. We brought together Indigenous women leaders to talk about how they got to where they were today and what kind of aspects of their life and resiliencies contributed to their success stories and healthy living. And so this was seen as a community gathering, which also allowed participation of our 3 community partners, who are the Mississaugas of the Credit First Nations, the Lake St. Martin First Nations in Manitoba, and an urban health center, the Douada-Desney Indigenous Health Center. And so, so it was an excellent gathering, and we'll be talking a little bit about the results from those early activities. Next slide, please. And so, as my colleague talked about a little bit earlier, this is a little bit on some of the statistics. The stakes of this research are high. As you all know, the Heart Stroke Foundation advises that generally there is that gender gap between men and women in health promotion, diagnosis, treatment, and research. with women lagging behind in all areas, while at the same time, 2/3 of the clinical heart disease research still focuses solely on men. And so for Indigenous women, this inequality is more severe because of many compounding factors, including higher rates of extreme poverty, poor access to health, education, healthy food, and clean water, and as a result of the long-reaching impact of discriminatory government policies, including residential schools and the 60 Scoop, that continue to impact Indigenous peoples intergenerationally. So Indigenous women also die from heart disease at a younger age, on average, than non-Indigenous women. And the Heart and Stroke reported in 2018 that Indigenous women experience a 53% higher mortality rate due to coronary heart disease compared to non-Indigenous women in Canada. However, some studies have found the mortality rate from CVDs to be up to 76% higher for Indigenous women. A 2012 study found that the risk of dying from cardiovascular disease compared to non-Indigenous cohort members was highest in the younger age groups and diminished with age. For Indigenous people aged 25 to 34, the risk of dying from cardiovascular disease was found to be 62% higher for Indigenous men and 217% higher for Indigenous women compared to their non-Indigenous counterparts. So traditional roles as Indigenous women are known to have traditional roles as strong leaders in Indigenous societies. And so this was part of the emphasis, was looking at what those roles are and how that contributes to positive health, as I mentioned earlier. Next slide, please. And so this is a schema developed by my research assistant, Dana, and Dana Hart, who's on the call, I believe. And so this we just tried to capture here to date in the project that showing that we have worked with our community partners to hold 3 community research storytelling circles. And so this allowed us to focus also to understand family and both men and women perspectives. And so we held these storytelling circles in deference to our partners who also saw this as an important opportunity to have that community level engagement that included men. So as the lives of women and their well-being are not disconnected from the men in their lives, it was important for our partners to have them engaged. So these storytelling circles happened throughout 2019, and the response was very positive. It's also a way to just, continue to foster that relationship building with participants, get them interested in the program, and also to have them talk about the various factors that were impacting their life. So it was really a good way to get them involved. And so the visual that you see was compiled by Dana after working through an in vivo analysis. And so it's kind of small print, but you can see quite a vast array of concepts that were gleaned from the analysis. Everything from, wanting more access to Indigenous knowledge, learning more about their language, talking about the things that were important to them in terms of ceremony, drumming, a holistic approach. So it was a very rich data source that we gleaned from those circles. And yeah, so next slide, please. And so in terms of knowledge translation, we managed to hold those 2 other research activities in March 2020 that I mentioned. And that was the Indigenous Women's Leaders Gathering and the community partner, what we called a Coming Together event. And so they were designed both as data collection and knowledge translation events. So on the first day, we had Indigenous women leaders, including academics, policymakers, community stakeholders from both Ontario and Manitoba, again, as I mentioned, to discuss the strength and resiliency and the barriers that they have faced and how they have dealt with them. And community members and stakeholders from each of our partners attended day 1, then returned for the Coming Together event on day 2, so that we could connect and share knowledge and experiences about the project. And both of these events featured panel discussions, teaching, small group storytelling circles, and a thematic mapping by the participants. Next slide, please. And so the COVID pandemic, like my two previous colleagues, have caused barriers to data collection in the project. We've been very sensitive to the burden on our community partners. Our community project leads are health directors, and so they have quite a burden of responsibilities, and they've had to prioritize and set the research agenda aside. So it's meant for us trying to be sensitive to their schedules and so forth, and so we've just nudged along as we are able to, and we are prepared again in this third wave and expect that we may indeed have further delays. So we have had to shift to online and socially distanced methods. So we have tried to accommodate that, work through what is required for the protocols through ethics. Had them nuanced by feedback from our community liaisons, and we are now putting it out there to see how many women we can get to be interviewed. We'll also be interviewing healthcare providers and traditional practitioners. So we're just embarking on that, and fingers crossed that we can move forward. Next slide, please. I guess that's it. So I'm open for questions from the participants. Thank you very much, Miigwech.
Thank you very much, Dr. Downey, for bringing us home. So we're now open to questions while we wait for some questions to come in. Perhaps we can get all of the panelists to unmute and present their videos. And maybe I can start with Dr. Foulds, and I'll have the other two panelists perhaps comment as well. Dr. Foulds, some of your work has been around cultural connectedness with the Métis population, in particular around cardiovascular health and risk. Curious to know from your perspective whether or not you've seen any differences in terms of these determinants amongst Indigenous living within their reserves versus urban settings, or across different Indigenous populations.
Yeah, so the data that I've seen so far, and I think the coming studies will give a much better understanding of those questions. There are some differences in terms of physical activity levels, northern or southern communities, or home, if your home community is on or off reserve. Actually, one of the most important parts or determinants that came forth so far is if you've had to leave your home community. So whether you've come from a reserve or not, but having to leave your community at some point seems to be a big determinant.
Dr. Nerenberg and Dr. Downey, any comments from your perspectives based on the work that you've done?
Yes, Dr. Randhawa, would you mind repeating the question?
The question around, cultural connectedness impacting cardiovascular health and risk, and whether or not different environments influence that risk, in particular, for example, if you're studying Indigenous persons living within their reserve settings, or when they migrate to urban settings. We know that I think, within the minority diaspora, when individuals move to different countries, I suspect that there's some environmental impact. I'm curious to know whether or not you've seen any of that in some of your work.
Yes, for sure. Thank you. When I mentioned the storytelling circles, it was, a very open format to have the women and community members feed into, how they understood their cardiovascular illness. And so, for example, in Lake St. Martin, Manitoba, who had been under all of the pressures, stress, and impact of evacuation related to forced funding by the government, living in hotels for up to 7 years, you know, family members, little children who, you know, would have been born on reserve but have been born in the city, and youth who are completely displaced in and elders living in hotels and trying to navigate that urban environment when they're used to on reserve. And so I wasn't surprised by the focus of the storytelling circles there, for example, and we saw similar you know, kind of responses in our other 2 partner storytelling circles. And so, you know, it really speaks to the broader issue of colonization, oppression, discrimination, anti-Indigenous racism, and you know, those determinants impacted by that forced evacuation for their communities. And you know, in fact, it's ongoing. You know, so it's 7 years being displaced, but now they're back in their communities that look very much like an urban town. And you know, so that readjustment period. So yeah, indeed, there is a connection, and they want to talk about the risk and you know, what they know from their physicians and other healthcare practitioners, but they also make strong connection to their sociocultural environments and those risk factors. It's a great question. Thank you.
Dr. Nerenberg, do you have any unique perspectives given the pregnant population cohort that you study? You're still on mute. It looks like we still can't hear you. I don't know if you could try unmuting again.
This 3rd time the charm there, but
it is.
So I think it's a really important question that you bring up, and I hope our research will advance the knowledge somewhat in that area. I think that I'm really fortunate to work with a PhD student in Toronto, and I think that her work is really going to advance that. That's Deborah Baden, and is looking to develop programs for interventions that are more tailored to culture, race, ethnicity. And so with some of the background work we're doing for our best practice statement, again, there's not a lot of evidence out there, so there certainly isn't anything that's more tailored to different groups. But what we're hoping to do is, through some subgroup analyses, determine whether the outcomes were affected by different factors, race, ethnicity, socioeconomic status, etc., so that we can start to collect a little bit of a signal of how we might be better able to tailor interventions. So we're far behind Heather and Bernice's work, and we'll answer the question as well as they will, but it'll be a starting point.
Before I let you go, Dr. Nirenberg, there's a question from the audience, which perhaps you can start off with, and then I'll move to Dr. Foltz and Dr. Downey. One of our participants asks, how can public health organizations best support Indigenous women's health? I know you've done a number of works that have led to health policy changes and participated in guidelines, documents. I'd like to hear from your unique perspective.
Can you, I don't know if I'm the best person to answer that question. I think Bernice and Heather, can you run it past me again? I missed the first half of that question. Yeah.
How can public health organizations best support Indigenous women's health?
Okay, I'm going to defer that to Heather and to Bernice. Honestly, I think they're much more informed than I. Yeah.
Fair enough. Dr. Foltz?
Well, I think there's addressing all these differences is a complicated and multi-layered solution. I think some of it is the relation aspect of approaching the way we engage in healthcare, that it's not the authoritarian, this is what you need to do, but this relationship about let's work together and what can we both bring to the table, and then working with communities at a community level rather than or even a family level as you're working together with your patients. That often what's
these underlying challenges are more than one person is experiencing. So there's opportunities to work in those higher level avenues.
Dr. Downey, you've had quite a bit of experience in working directly with the community in Ontario. What is your perspective? Have you had any interactions with public health organizations at the present?
Well, of course, we have a very vibrant Indigenous public health environment in Canada. We have the National Collaborating Centre for Indigenous Health that really provides a wide array of resources and hosts seminars that talk about Indigenous health system reform and health equity. And further to my colleagues' comments on both the relational approach and the community engagement, I strongly agree with that. I think, I would take it to the next level and, advocate that we can collectively perpetuate colonization and oppression without making the strong efforts to system reform. And so as an example of that issue in our current climate with COVID, there is such a need for racialized data. And it's a major systemic barrier to not understand the nuance of the issues related to COVID, to vaccination, to risk, transmission risk. And so that's a concrete move forward that several of us are trying to engage in, but has been talked about for quite some time at the national and international levels. And so there's an obligation for public health to, take a deep dive into that with Indigenous peoples and make that happen. So that's one example, but also, to support this work, I, really applaud the Heart and Stroke Foundation for giving us this opportunity to understand that sociocultural perspective. Quick example is one of the other activities that we're engaged in is working with fluent Ojibwe language speakers, because a lot of the concepts and beliefs and words related to health and well-being are captured in our language. And so we're going to be translating that data to understand, that unique perspective that is only in the language, and sharing that with our people as well as our healthcare providers. So yeah, it's a very challenging aspect. It's an excellent question. And there are lots of people willing to work with public health to make this happen.
So speaking about, the opportunity to gain this type of focused funding from the Heart and Stroke Foundation, we have another question that's come about, what is participating in a targeted funding opportunity like this meant to you and your work? And secondly, how can funders or funding agencies become more sophisticated in expanding funding guidelines to encourage this type of work, to be able to then facilitate the change that's necessary? Perhaps I can start with you, Dr. Downey.
Oh, sure. Thank you. Well, it was an incredible opportunity. It's a little bit of a oxymoron in that I'm called an early career researcher, but I'm closer to the end of my career than probably my colleagues. But it was an amazing opportunity. I mean, I returned to school at the tender age of 52 because I felt that, one, I had questions related to my area of research, and two, I felt that my ability to influence would be greater with those letters behind my name, and I'd be talking to different people, and that has in fact come true. At the time, I was engaged in our work at McMaster, which is the development of an Indigenous health strategic plan, and which has since resulted in establishing an Indigenous Health Learning Lodge. And so when that work began and I got notice of this opportunity, I was like, heck, I don't have time for that. And then as I was prompted by my director of research and read it closely, I thought, well, this is my dissertation. This is an opportunity to dig deeper. And so it really has provided that opportunity to work with my colleagues on this and our community partners to do a deeper dive and hopefully to make a contribution to the Indigenous heart health environment for women. So very important, and I'm very honored to be able to do this work. Miigwech.
Dr. Nirenberg, any thoughts?
Yeah, I think Bernice said that really well. I think I would like to add to it that I think one of the reasons why I'm so grateful for this funding, it's hard sometimes to find a home for these under-researched areas. And, I got another no this morning, so I have to tell myself it was just the wrong opportunity. But while I was talking to a colleague just to talk about, how did I miss this? How did it not align? One of the issues is that because these are under-researched areas, there's not the same track record. If you want to compare with other active teams, there's not the same research infrastructure, research network, track record. So when you go into a bigger competition, you're competing against these other programs, which are very important too. And so that's where this dedicated funding to these, I don't want to call them orphan areas, but these under-researched areas are really important to try to raise the playing field so that, our teams will now have the same experience and expertise that when we go into the next round of funding, we may be more competitive. So that's one advantage where these organizations are really helping out. But also these dedicated calls, they're also saying to the research community, these are important areas, I'm bringing that to the forefront so that other people may actually get interested. Researchers have to go where the money is. If the money's for women's heart health, they go there. If the money's for Indigenous, they'll go there. But that's the way that you stimulate more research and more trainees to be interested in the area. So I think if other groups can follow Heart and Stroke's model for this, I think we'll be able to fill a lot more important research gaps in Canada.
Dr. Foltz, your thoughts, and then we have time for maybe one more question.
Sure, yeah, my colleagues have made some really great points. I think one of the real benefits of targeted calls for Indigenous health is the difference in the way it's structured, because I'm partnering with the community and doing knowledge translation with the community before we move forward with academic publications or the community engagement. Like the process takes longer and it looks a bit different, and the outputs that really matter might be different. And so a targeted call would have, I think, experts who are reviewing it who would understand that type of work, rather than somebody in a completely unrelated field who might not have that kind of background with the type of work and what it looks like.
So we'll ask one more question, and maybe I can take a sort of a step back and just curious from your perspective as educators and researchers, how has this opportunity impacted your role in these areas towards mentoring both clinical and research trainees? Just from a sort of networking and mentorship perspective, we all know that it's important to facilitate growth and interest in areas of the work that you're doing. Perhaps Dr. Foulds, if you want to start.
Yeah, I think that certainly funding gives more opportunities to support students and build the capacity of mentees that I'm working with. And these kind of opportunities are great for networking and building collaboration. And so I think that the call has certainly brought support in both directions, students and trainees that I'm working with, and as well as colleagues and collaborators to get to know.
Dr. Nerenberg?
Yeah, I agree with Heather, and just to add something as well, I think that through Heart and Stroke's initiative, real emphasis on advancing sex and gender research, I think it's really advanced not just my own skills in that area, but other members involved in Heart and Stroke's work. But we've been able to take that to other colleagues, to be peer mentors to other colleagues as sex and gender champions on other research in other fields. So I think it's really extended the reach beyond just the usual trainees, early career investigators, but even amongst our mid and senior careers, bringing that expertise on sex and gender to them.
And Dr. Downey, I'll finalize with you before I hand it back over to Kristen.
Yes, thank you. So yeah, the capacity building and mentoring was a very important aspect of the project for our team. We built into the team structure 3 community liaison positions so that, you know, it would relieve the burden of team interface and logistics planning and coordination and all of that. And we released resources to each community partner specifically for that purpose. And in some cases, we took the lead on recruiting someone for that role for them. Another aspect of mentoring and capacity building, you know, in the community, we often have in the traditional healing model, if you will, that traditional healers or practitioners or elders often choose to mentor individuals in that area of their work. And they can be seen as knowledge helpers, if you will, or apprentices. And we try to engage in that approach because those people are not often eligible for any funding to do their work, you know, never mind paying an assistant or a helper. And the helpers themselves may never be in an academic environment, but they are learning and they are often in an apprenticeship situation. And so we worked through this project and through our SHRC funding base to add resources after the fact to accommodate that unique aspect of capacity building, so that it's not just the academic community that benefits from the mentoring and capacity building, but the communities themselves will benefit from that and be able to carry on those traditions of healing and traditional approaches.
Thank you very much. That's great. Thank you very much, Drs. Foulds, Nerenberg, and Downey, for wonderful presentations of the work that you're doing. We look forward to hearing more and seeing these published in the near future. And with that, I'd like to hand back to Kristen Honhurst. Thank you for the opportunity to moderate today's session. Kristen?
Thanks, Dr. Randhawa, and thank you to our panel. It's such a delight to have you all together, kind of in one place, virtually anyway, finally to present on your work. So I'm very grateful for that. And I just want to highlight one more time for everyone that we have 2 more webinars coming up as part of this series. So tomorrow at the same time to hear from another subset of some of the researchers funded through this initiative, and then next week as we look forward. And I will conclude by wishing you all well. Please stay healthy, and we look forward to continuing to advance this work together. Thank you.
Thanks for your assistance, Kristen.
Kristen, thanks everyone.
Dr. Randhawa.
Thank you.